We are live.
Good evening, everyone. Welcome to iFocus Online Lecture 210 and Retina Session 62. And this is the exam special. And today we have with us Dr. Manoj Khatri sir talking on long cases in retina. I request Dr. Lalit Verma sir to please introduce Dr. Manoj Khatri sir.
Thank you, Rolika. Thank you, Santosh. You see, last time we had a lot of discussion on short case, and today we have short case was discussed by Chitra, and today we have another young person, very young person in fact, and a very dear good friend of mine who will be taking us through this journey of long case. But you see, what I wanted to highlight regarding Manoj Khatri is that you see on the slide itself always smiling face. Very, very important for retina people. And again, you see, at this very young age, very accomplished, very, very accomplished. This is what is heartening to see. You see, he graduated in 2001, and in this short span of time, how much accomplishments he has. You see the role in AIOS, VRSI, DOS, everywhere. And I know he is one of the very nice, very, very polished kind of surgeon because he will do live surgery in majority of the conferences, and he will take the most machine which is Indian, because by and large people will take Accurus or high-end machines, Alcon, Constellation, but he will make the people realize that everything is possible with even the Indian machine. And that, I think, is one of the single thing which I like about him, is because he accomplished everything with that Indian machine. And I'm very proud of Manoj Khatri, the way he demonstrates the live surgery on Indian machine. It gives confidence to the budding surgeon. Because remember, budding surgeon may not have so much of finance, but he can easily afford an Indian vitreoretinal machine. So Manoj, really proud of your accomplishments and the way you carry on with the live surgeries. And the entire CFS team is really looking forward and very proud of you that you have accepted this, because the approach to a short case and long case is totally different. Long case, we go into depths of findings, depths of differential diagnosis, depths of management, everything. The short cases, primarily confined towards finding, and we normally do not discuss about too much details about management and all. So I hope after all the people here and all the people in future also go to your talks on YouTube and here, they will become much wiser that how to approach a long case in retina in general. So over to you, Manoj.
Thank you so much, sir. Good evening, one and all. And thanks a lot, Dr. Santosh sir, as well, for the kind invitation. Let's move on to the presentation per se. Are my slides visible?
Yeah.
Yes, sir.
Yeah, and I'm audible as well.
Yes.
So exam-oriented long cases in retina is a topic assigned to me for today evening. What I want to highlight before we start the exam cases is the intent of practical examinations. We recently concluded DNB exam 2 weeks back, so the candidates were mostly nervous before the exams. But what I'm looking at is like application of knowledge which is accumulated over years by the candidate. Clinical skills and acumen, definitely yes. What is presence of mind of that particular candidate, performing under stress, and basically whether you are well versed with the basics or not. So this is what is very, very important. Now, when we look at the steps and examining and presenting a case, we need to have a thorough history taking in a long case examination. Dilated detailed examination, documentation is quick enough, should be quick enough, and we are not looking at what Dr. Lalit said already on a diagnosis. We are looking at what are probable differential diagnoses, investigations, and what is the treatment plan. A quick note about good history taking is history of presenting illness relevant to the case. Most often or not, we will be knowing as what is the case, what we are dealing with, what are the relevant past systemic and medical and surgical history, past authentic medical and surgical history, family history whether relevant or not in cases of retinitis pigmentosa, and what are the personal history. Now the question here comes is, in that limited given times, about 15 to 20 minutes, you need to examine the case, you need to present the case, and you need to defend your case. So just a quick assessment of the visual acuity, don't be into detail too much. What is the intraocular pressure? This is quite relevant. Whether the media clarity is there or not. Quickly, whether the patient has any color vision problem or any visual field defects in form of Amsler grid or confrontation test, which you want to quickly demonstrate. So the key here is your management of time. Then you come to the examination. I always highlight this importance is you get your tools along with you, whether it is 78D, 90D or indirect ophthalmoscopy or direct ophthalmoscopy. You are much more familiar with your own tools, so don't rely on the examination center to provide you those tools, though there will be everything. But even a torchlight, if you have your own, you are familiar with, and then you try to do cover and throw, whichever test you want to do it, in your own way. So familiarize yourself with the surroundings quite, rapidly, and then go systemically. First is just an external torchlight examination, right from head posture, facial asymmetry. All of us are learned here, so I don't have to give importance of each and everything. Quickly move to slit lamp. And then biomicroscopy, whichever you are comfortable with, whether you are comfortable with direct ophthalmoscope, which we don't use it nowadays, but people, examiners from government medical colleges, this is their favorite question, which side you will face you what, and what are the each pointer on the direct ophthalmoscope and so on. So one should be familiarized with the equipments what are there in the retinal examination, but because in Viva this becomes one of the favorite question of the examiner. And then what are the different parts and what are the different apertures which can be used for each and every use. Then importance of good red reflex, that means whether from a distant direct ophthalmoscopy, whichever tool, whether it is indirect ophthalmoscope or a direct ophthalmoscope, you are able to see any kind of a white reflex or any kind of a media opacity. This is very, very important, especially in extremes of the age group, whether the patient is young or the old patient. So this kind of thing should be given importance before just touching the patient or asking the patients, so this can save you a lot of time, and you can come to a probable conclusion that this patient has this particular pathology. You can document the findings quite easily and lead the examiner in such a way that you lead the exam rather than examiner leading to you. Quickly, an assessment of slit lamp biomicroscopy should be done in your routine OPD before we go direct into the examination. This is very, very important. All the examiners are giving a lot of importance to a good slit lamp biomicroscopy examination, and not more so for indirect ophthalmoscopy, because this is a standard of care which has been expected from each and every candidate. So 90D we are all familiar with. 78D we'll just, due to interest of time, we'll skip all these things. Rarely they may ask you what is Goldman 3 mirror lens and why it is used for. And these are the indirect what we should be familiar with. Normally these indirect ophthalmoscopes have been provided by at each and every place, and quickly you should get hang of it and get an assessment done in whichever case has been given to you. So another common question asked before we even start examining or start your Viva is, have you done a direct ophthalmoscopic examination or an indirect ophthalmoscopic examination of that particular patient? And whenever you have done direct and indirect examination, you should know merits of each and every checks. So this is what is required from each and every candidate. Now a paper given to you should document quickly what are the retinal findings in a particular case are. It can be as simple as documenting the ciliary processes or the pars plana region or the ora serrata, and also the retinal detachment or the vein occlusion, whatever findings has been given. So this kind of a charting can be done. You just have to draw 3 circles. Each circle, first one represents equator, the seconds represent ora, and the third represents the ciliary processes. And once the examiner sees this drawing in your hand, there is not much to ask. They know, okay, your examination is thorough. And these are all where the vortex will exit the eye, and quickly right eye and the left eye. So the disc will be on the right side of you in the right, and on the left side for you for the left eye. And this has been discussed yesterday by Dr. Chitra as well, as the importance of color fundus photography drawing. So this is very, very important. It doesn't take too much of time. We don't have to give into such finer details. Quickly we have to see whether there is a retinal detachment or exudation or some kind of weak areas in the retina, and you can get away with this. So this is just a brief as how we are going to examine, how we are going to start the examination, how are we going to document, which is of very important thing in especially in retina, because everything is image based or an imaginary thing. You are describing a case which the examiner has to understand on a differential diagnosis, then what are the investigations required and how are you going to manage this case. So the retinal findings of each eye, right eye, left eye, should be documented. Even if it is the problem is only in one eye, make it a point that you examine the other eye and document the findings of the other eye as well, even if it is normal, and then only go to it, go for further discussion. So quickly we start with how is the media clarity, the disc, the vessels, macula, background retina, and the periphery. So what are the list of possible long cases? So this we shortlisted from the commonly conducted exams nowadays. So it can be any kind of a diabetic retinopathy, right from moderate diabetic retinopathy to a tractional retinal detachment or combined retinal detachment. Any kind of retinal vein occlusion, this is another common thing what is favorite of examiners. Any kind of macular degeneration, especially in form of choroidal neovascular membrane. Central serous retinopathy, though only chronic cases we keep it, so this can be sometimes kept. Definitely retinal dystrophies, and more so involving rod cone dystrophies. The simpler one are retinitis pigmentosa. Very rarely some kind of Eales disease and neovascular glaucoma. And in surgical retina cases, you can have either vitreous hemorrhage of unknown origin, or we need to find out the cause. Retinal detachment, which is one of the favorites, especially the chronic detachments, epiretinal membrane, and macular hole. So these are the common, but mind you, to trick the candidate, the cases can be flipped over a period of time. So when we come to the simpler cases like macular degeneration, what can be asked in macular degeneration is something like a dry macular degeneration to start with. This is very common. So nowadays dry macular degeneration, as we all know, the lot of interest have been highlighted in imaging and treatment. So we should not only be focusing only on the finding, we should also be looking at that what treatment for the future can be offered for this patient. So this is of interest for particular examiners, especially if the examiner is from a private practice side. So they will be asking you what is there in gene therapy to offer, what is there in the ARETS formulation, and so on. So we should be well versed with all these modalities of nomenclature what has been there. The what thing they are looking at whether you are dealing only with dry macular degeneration or there is a component of wet macular degeneration as well. So the common things are drusense, as we all know. This is the one of the first cases which was kept by us in the recently concluded exam. And what we are looking at is whether the candidate is also well versed in reading the optical coherence tomography scan of that particular patient associated with it, differentiating drusense of various forms, and whether the drusense have any clinical other significance, like in this case where we have a reticular drusense, and in this case we have cuticular drusense. So the importance of this is like these patients are more prone for development of choroidal neovascular membrane. Sorry. Sir, are my slides visible?
Slides are visible, but you have to make it a slideshow. Yeah, okay now. Okay now.
Sir, we'll be going by case comments, or how you want to take it?
After two cases or so, we discuss them out. Otherwise, time at the end becomes really less.
Okay.
So maybe if suppose you are discussing AMD and one more this thing, then we take some questions. If there are no questions, then we proceed for another two entities, then we come back.
Okay, sir. So we are just looking at this kind of a dentate process in this OCT scan to basically determine whether this patient is going more prone for neovascular AMD in form of a reticular drusense as compared to a cuticular drusense, which can be nascent over a period of time for a long time. What is the ARETS 2 recommendation? This is another commonly asked questions in Viva. We should be familiar. You just have to by heart this. We have vitamin C and E, then we have zinc oxide, cupric oxide, then you have lutein and zeaxanthin. So these 6 components have to be there. And as of now, there is no Indian formulation which is available having this in correct concentration. So we should be just familiarized with this, that this is what is required, and there should not be any beta carotene. Okay. Now, choroidal neovascular membrane, what are the presenting complaints? The patient can have metamorphosis of various origins, so we should have to document this quickly, and these patients most often are not, or in some kind of a treatment. So, causes of choroidal neovascular membrane, neovascular like age-related macular degeneration is the most common one, because we should be always familiar with the other causes. So, this is again the second question will be asked, like what are the other causes. So it can be pathological myopia, angioid streaks, choroidal hemangioma, nevi, and so on. So these things has to be are expected by the candidates to be known. Then what are the risk factors which can be modifiable and non-modifiable risk factors? So this is another favorite examiner. What are the modifiable risk factors and what are the non-modifiable risk factors? So this we should be aware of. So in non-modified risk factors, there is age, gender. Females are more prone, especially in the elderly age group, ethnicity, genetic factors, iris colors, and there are some kind of polymorphism which is present. And then what is the pathogenesis of this particular disease? This is one of the favorite question of any examiner. If you have a case of neovascular AMD, how does the degeneration starts? Where does the problem happens? What are new vessels? How do they grow? What is the breakdown on the Brooks membrane? Why does it occurs? Why does the blood vessels leak? And how does the fluids get accumulated? So this is what a pathogenesis starting from inflammatory cytokines. What is the role of everything, and also what is the role of VEGF, that is vascular endothelial growth factor. When there is overexpressed, how does it overexpress, and what, because the entire treatment modality is been around this particular protein. So we should be very familiar with this. And then what are the modulators of angiogenesis? This is another typically asked questions. In our recently concluded exam, we found that the candidates were not aware of the term called angiogenesis, and you should not be caught without knowing the correct terminologies for angiogenesis, and what are the different steps of angiogenesis, what is the importance of every vascular endothelial growth factor, right from VEGF to FGF and PEGF. So this is what is required on a basic level. And then what are the findings in neovascular AMD case, and if a patient will be given to you, this was one of the case in the MS exam, and this was a subretinal hemorrhage which was misdiagnosed as having a pre-retinal hemorrhage. So you should not make this kind of blunders. This patient has a darkish bleeding here, and which the margins are not very clearly defined. So this typically indicates that this problem is slightly deeper than compared to superficial. If the margins are quite well delineated, then it can be a pre-retinal or intraretinal hemorrhage. So once you see and this kind of a macular degeneration changes here, this typically denotes that this patient has a choroidal neovascular membrane. So you should be little careful in picking up the findings. And also in end-stage cases, because these patients we cannot keep active cases, so disciform scar is one of the commonly kept case, and also sometimes pigment epithelial detachment. When the patient has a pigment epithelial detachment in any form, in this kind of a chronic patient like this who has a pigment epithelial detachment which is a long-standing, this can be kept. Or sometimes a serious kind of a pigment epithelial detachment where there is nothing much to offer to the patient on the treatment part. So this can be kept as a long case, and the discussion can be going through another thing. That another chronic case in macular degeneration can be this kind of a drusonite pigment epithelial detachment. We should be very confident in saying that this drusonite pigment epithelial detachment classifies as PED when this distance increases more than 350 microns, that is somewhere close to around to foveal avascular zone. And then hemorrhagic PEDs can be kept. Now coming to the most favorite question is, what is the role of fluorescein angiography in macular degeneration, especially whenever you are suspecting a wet type of a macular degeneration. Basically we want to denote the classic CNVM versus occult CNVM. In occult CNVM, whether the leakage is happening early or the leakage is happening late. So these are couple of cases which can show here that there is a classic membrane. That means both in intensity and size, this membrane is growing over a period of time in a lacy pattern. That means the pattern is not very clearly defined. So these are only 2 points which are looked as an answer for the particular candidate. And when you have a fibrovascular PED, you will have something called as a stippling fluorescence. So this is a typical example of a patient who has a stippling fluorescence. So rest of the nitty-gritties you don't have to be very well versed with, but if you know these 2 points for classic and occult CNVM, then that is more than enough. And depending on the type of fluorescence and the amount of fluorescence, predominantly we classify these patients. We have subfoveal, juxtafoveal or extrafoveal CNVM, and which is increasing or decreasing in size over a period of time. So what typically the examiner is asking you or looking for is the answer is whether this CNVM is present beneath the retinal pigment epithelium. So this is the retinal pigment epithelium here. We all of us know if the CNVM predominantly stays below this, that is a type 1 CNVM. When the CNVM breaks through retinal pigment epithelium, it becomes type 2 CNVM. And the commonly favorite question nowadays is something of recent interest is type 3 CNVM. That means whenever you have an intraretinal component of this choroidal neovascular membrane, or it is also called as retinal anastomosis or retinal CNVM. So these are the commonly asked questions, and these are the commonly anticipated answers which are required from the candidate. Treatment, all of us know, this is a day in and day out procedure. Only 2 types of treatments are available. One is intravitreal anti-VEGF therapy and photodynamic therapy. I will be skipping all these slides because I think most of us who are present here, they all know what is bevacizumab. Basically the differentiation between the bevacizumab, ranibizumab, and what are the common trials. So the Marina and Anchor were the first trials for ranibizumab. Just a brief, you should know what is the aim of the trial and what was the result of the trial, and what the trial changed or transformed the way we treat these patients. So if you know this much, that is more than enough. If you are doing too well, then the commonly asked trials are the Pronto trial and the Sailor studies in select cases, Sailor or Harbor. The CAT came later. You just have to remember that this was like bevacizumab versus ranibizumab, just a comparison trial, and which just told us that both are equally efficient molecules. So other thing, even if you don't know, doesn't matter much, but just what was the name of the trial, what was the primary aim of the trial, and what was the final outcome, that is what is required or anticipated from the particular candidate. The recent anti-VEGF molecules, even if you know the name, that is more than enough. One is called brolucizumab, faricimab, and conberserpent. So these are the 3 ones which are of common interest nowadays. If you are doing little better, then the next question will be what is port delivery system. So these are just sustained release drugs which can be given over a period of time, and any adverse effect of this anti-VEGF, so we should be knowing. Photodynamic therapy as of now is not available in India, and then but you just be knowing the brief how it is given, because this is the next commonly asked questions after fundus fluorescein angiography, and whether there are any surgical options. Lalit sir, you want to give any comment, or shall we move to diabetic retinopathy?
No, I thought this is a very important disease we have covered. In case there are questions, we can take that. In case not, then maybe we can move forward. So any questions regarding the first ARMD, anybody would like to clarify from Dr. Manoj?
No questions till now on the social media. If the hot seat participants have any questions, I think you can clarify right now related to ARMD.
There has been, Manoj, a lot of repetition also. So let's go on and discuss one more disease, and then maybe Shefali will come back.
Yes.
Sure.
Sure, sir.
Okay.
One common kept exam case can be a diabetic retinopathy with any severity. Most commonly a non-proliferative diabetic retinopathy or proliferative diabetic retinopathy. These are the commonest ones. So in non-proliferative diabetic retinopathy, you start from the disc, the media, first your media clarity, the disc, how are the vessels which are originating from the disc, and what is the level of exudation, how much of the exudation is there, what are the dot blot hemorrhages, do you see any venous changes. Very rarely if you find any kind of neovascularization elsewhere, and this is what commonly asked or commonly looked findings are. But whenever we are examining a case like this, the systemic history also plays a very vital role. So we should not be concentrating only on the ocular findings. We should also be concentrating what are the systemic findings or the systemic problem the patient has, right from anemia, diabetic status, and so on, and then take it forward from there. So the other cases which can be little chronic and kept are, this is kind of a proliferative diabetic retinopathy with breakthrough hemorrhages or a tractional retinal detachment associated with it, or very rarely a combined retinal detachment. Risk factors we all know that can be hypertension, hyperlipidemia, smoking, renal disease, pregnancy and anemia. So these kind of 6 things you should be always knowing it, apart from uncontrolled diabetes and the duration of diabetes. Classification of DR is very, very important. We should be just very thorough with this. What is the classification of mild, moderate, severe and proliferative? I think there was a repetition of this. I'll just skip this. But another important thing which has been looked into it, though we don't use the definition anymore, clinically significant macular edema, we just use a definition nowadays which has been given by drca.net, whether the center of the fovea is involved or center is not involved. It's called a center involving or non-center involving. But for some old examiners, their still favorite question is what is clinically significant macular edema. So it can be involvement of the center of the fovea along with some adjacent thickening, or the fluid, that is the edema which is present there. So in 3 categories, okay. And here the importance is given to the size, the location, so that is 500 microns, and in the last it is 1 disc diameter. So we should be really careful with this. And then the second classification which has been expected from the candidate is early proliferative diabetic retinopathy and what is the high risk proliferative diabetic retinopathy. So this we should be knowing. Whenever the disease doesn't involve more than 1/3 of the disc diameter with no vitreous hemorrhage, it is early proliferative diabetic retinopathy, and whenever this 1/3 becomes half or more than 1, then it becomes a high risk PDR. So this is very important questions nowadays, because this category of patients, they need more aggressive treatment as compared to early stage. So the lesions in diabetic retinopathy can be anything right from microaneurysms to NBD and NBE, and we should not be missing the findings. The importance is given only to the findings and what is the involvement of diabetic macular edema, whether the center is involved or the center is not involved. Still, there is the importance of treating when we comes to the discussion part for these cases, because these are straightforward cases. A lot of importance still has been given to the importance of focal laser photocoagulation in the management part. So we should be little aware of this, in spite of having only been known as what are the anti-VEGF injections which are available, and what is the pan-retinal photocoagulation, the criteria, the principles, and how will you do it, how many sittings you want to do it, and so on. Now in very rare cases where we have this kind of patients, vitrectomy is an indication. Basically the examiner is not looking the steps of vitrectomy from you, they just want to know what are the common indications of diabetic in a patient with diabetes or a proliferative diabetic retinopathy, and how will you just advise. So you just have to say any kind of traction on the fovea, whether it is tractional retinal detachment or epiretinal membrane. This is a clear-cut case where the patient will need vitrectomy at some stage, and you will counsel the patient accordingly. Commonly asked other questions are, what are the trials associated with diabetic retinopathy? So again, in these trials, 3 things were very important. What is the purpose of the trial? So this was one of the landmark study called as Wisconsin Epidemiological Study of Diabetic Retinopathy. Similar study has been done from India called as Ascent Dreams, that was done by Shankar Nitrale group. It was part of it. So we should be just knowing what is the purpose of these studies and what are the end result of the studies. These are the all favorite questions. In the interest of time, we will not be able to go through all this, but make sure that you know about all these things in detail, at least the aim and what was the end result of the study. And what is the second most important study for diabetic retinopathy is diabetic retinopathy study. It is called as DRS, because this was the study which changed the dynamics, the way we used to treat these patients. So we should be knowing again the DRS, what was the purpose of DRS and what was the end point of DRS, like what has been told by the study after about 10 years or so, and what are the high risk categories or high risk characteristics which we already discussed. Any kind of vitreous hemorrhage or neovessels which are more than 1/3 of the disc area, or neovascularization elsewhere which is more than half of the disc area. So these 2 points we should be knowing quite well. And so primary outcomes and secondary outcomes, if you know this, that is good enough. If you don't know, that also doesn't matter much. And the next important study is ETDRS, that is early treatment diabetic retinopathy study. So this also we should be knowing in detail what was the purpose of the study and what was the final outcome of the study. So just to conclude, that ETDRS was again a landmark trial which just told us how to manage NPDR patient, that is non-proliferative diabetic retinopathy versus PDR patients, and how are you going to manage mild to moderate NPDR with macular edema and so on, and what is the role of aspirin. So they clearly said that there was no beneficial effect of aspirin, that is a systemic drug. And last is DCCT, that is Diabetes Control and Complications Trial, because DCCT trial from UK clearly told that the systemic control plays a very big role in the management of both type 1 and type 2 diabetes. So this we should be knowing along with UKPDS in a small brief summary. DRVS, even if you don't know, doesn't matter much. I have just put for the sake of completion, because if the Viva is going on the surgical side, the DRVS makes importance of DRVS comes. Last thing we should be knowing, drcr.net. There are a lot of protocols from drcr.net, but we should not be aware of each and every protocol is from protocol A to protocol Z, and now double digits have also come. But just even if you know what was the basic aim of drcr.net and why they wanted to study, so basically there are only three aims of this drcr.net. They wanted to simplify the definition, whether they are reproducible or not, and whether the treatment can be standardized across the globe, and the last one was whether you can minimize the duration of treatment and minimize the treatment burden for our valuable patients. So this was just the aim of drcr.net, which is still going on. Sir, shall I move to RVOs, or we'll take some questions or comments?
We have questions.
There is one question which was there, was that is recalcitrant edema DME same as non-resolving DME?
No, non-resolving DME can be due to systemic factors as well, but the recalcitrant edema most commonly can be due to local factors, that is ophthalmic factors. The treatment is...
Yeah. So recalcitrant generally term, although sometimes people use it, interchangeably also. But
yes,
non-resolving means, as it is very apparent from the term itself, that it does not resolve.
Yes.
Okay. But recalcitrant, maybe there are ocular factors which are responsible, something like traction or, which is not allowing it to settle down. So this edema becomes non-responsive. So there could be, some issues. Initially, some DMEs are responding, then it becomes recalcitrant because of presence of VMT or some kind of intramacular traction. So other question which is there, Manoj, is tell us about steroids, mode of delivery of steroids. So I think this was covered, Manoj, if you want to evaluate about steroids in DME.
It's already been covered. I was supposed to cover that in vein occlusion, but just a steroid is commonly used are intravitreal triamcinolone acetonide and a dexamethasone implant. Dexamethasone implant, two things you just have to tell the examiner, that it's a sustained release device. So the drug is released over a period of 3 to 6 months in a sustained release fashion, and the dose which is been administered is a very micron level dose. So the ocular and the systemic side effects are practically negligible. So this is what they are looking for, and any steroid has a role of increasing glaucoma of any variety in the eye. So this is what is required.
So Dhanalakshmi, steroids are generally not the first line of management in DME. Although there are indications of giving steroids, most of us start treatment with anti-VEGF. So 3 steroids are used. One is triamcinolone acetonide, second is dexamethasone implant, and third, which is the fluocinolone. So 3 kinds of steroids are used. And fluocinolone, FAME study was done for that. That lasts for nearly 5 years, but that is not available in India. Fluocinolone implant, although it has received approval in Europe as well as very widely used in Europe. But in our country, either we use triamcinolone acetonide or we use what you were saying about Ozudrex, that is Dexa implant. Each has its advantages and disadvantages. You see, by and large, the triamcinolone is a poor man's choice in the sense that there are issues with triamcinolone, like possibility of rise of pressure is much higher, and you cannot, then you have to do surgery in case, because you can't predict the response, and the duration of this thing may be lesser. But believe me, triamcinolone also works pretty well. You see, previously, couple of years back, maybe a decade back, all of us used to use intravitreal transdermal in management of DME. But later on, you see, because of sustained delivery and Osutrex, remember, is a 22 gauge instrument. So you have to deliver it intravitreally very, very carefully. And there have been mishaps which have been reported with this. So we will know. Any other thing, Dinesh, you want to know about steroids? Or this answers?
I think Dr. Piyushi has raised her hand. Dr. Piyushi, do you have any questions?
Yeah, please.
Yes, sir, I just wanted to ask, sir, is there any role of
is there a role of?
Not very well. You're clearly
Not
audible.
very well audible, Dr. Piyushi. Can you repeat the question, please?
is there any role of test like urea and creatinine in a case of diabetic macular edema?
Still, I could not. The role of what in DME? What role of what?
I think it will be better, Piyushi, if you can write it on the chat box. We'll be happy to take it at the end of the discussion. We're not able to hear you very clearly. Just put it on the chat box and we shall just take it at the end of the discussion. I think so. We got disconnected. Maybe we can move ahead and probably we can take it.
I think let's go on to RVOs.
Can be of varied presentation, as we all aware. And this is a typical example of patient with ischemic central retinal vein occlusions, where we have involvement of retinal retina in form of diffuse dot and blot hemorrhages, along with little pallor of the retina, and you cannot make out much details right from the optic nerve head to the retinal periphery. But what's most important is if you can just draw this simple diagram in the paper what has been given to you, as where is the expected problem or the pathogenesis in that particular patient, what you are expecting it. So this is a picture showing lamina cribrosa level here. The block can be before the lamina cribrosa, just before the branching of the vessels. So this can be a central retinal vein occlusions, or one of the vessels can get occluded here, which can result in a branch retinal vein occlusion and so on, or this block can be behind the lamina cribrosa. So this is one etiological factor. The second etiological factor what we know is the AV crossing changes, that is arteriovenous crossing changes. So these are the two things. The examiner is not interested in knowing how are you going to manage this patient. They are interested in knowing what is the pathogenesis of retinal vein occlusion, because this is a very critical picture or very critical slide. So again, I reinstated lamina cribrosa, just draw like this, whether you are expecting a problem before, that is pre-lamina cribrosa or post-lamina cribrosa, or you are expecting a problem with the optic the vessel sheath, or you are expecting within the vessel wall itself, or with the blood flow. So if you tell this many things and with the presentation, because most often or not this patient has typical presentation like this is an evolving central retinal vein occlusions, or this is a full blown hemiretinal vein occlusion. So these are all established findings, nothing much to discuss here. But when you know what are the pathogenesis and where you are expecting the pathogenesis to be originated from, the rest of the viva becomes very, very simple. This patient has presence of more like a cotton wool spots in a young patient, so you are also going to suspect some kind of underlying uveitic problem in this patient. And definitely the prevalence and so on will go on right from history, what this patient presents as a history, and what are the causes which we already discussed. And based on your etiological finding, you can see whether the problem is lying at the optic nerve head per se, or it is behind the optic nerve head. If the patient has any past history of thromboembolic disease, associated glaucoma, any kind of mass lesion which is compressing the optic nerve head, whether the patient also has hypermetropia, any cardiovascular risk factor, and so on. So once you classify your patient according to these etiological factors, the rest of the viva becomes very, very easy. We will not go in details of non-ischemic versus ischemic CRVO. This all of you must be knowing, and this is what is expected from all of you to be known. But what are the differential diagnoses in a patient with vein occlusions? What you are looking at, it commonly are diabetic retinopathy, anemic retinopathy, venous stasis retinopathy, and rarely ocular ischemic syndrome. So these four things you should be aware of. How are you going to manage? Is more or less similar as compared to the management of diabetic retinopathy. But again, here 4 studies you should be aware of. One is a CVOS study, that is Central Retinal Vein Occlusion Study. What was the aim of the study and what was the final outcome? Another one was BVOS study, that was Branch Retinal Vein Occlusion Study. We should be knowing this. And the recent ones are Cruise and Horizon. Even if you know this much, that is more than enough. When you come to the trials related to the steroids, the SCORE trial, which is the commonly asked trial, what was the primary outcome of this trial and how does it define the role of Ozurdex in the use of management of retinal vein occlusions. So this much is more than enough. And if the media is hazy, then we can have other modes of treatment, right, in form of vitrectomy with endolaser or retinopexy or panretinal photocoagulations and so on. And if the patient has most common disease associated with this is always a glaucoma, so we should be ruling out glaucoma and knowing what stage the patient has glaucoma and how are you going to medically manage the glaucoma, which is equally very important. And in very rare cases, what are the surgical management options available. So this is what about vein occlusions. If you don't have any questions, quickly we'll move to macular pathologies. I think we'll move on.
We have a few questions.
There is a question, Manoj. Is there any role of kidney function test in a patient of diabetic macular edema?
Yes, definitely there is a role of kidney function test, which we mentioned here is like you need to ask for a systemic history, and definitely patients creatinine level and has to be checked for 2 things. One is mostly in renal failure patients, the examiner expect that you will be telling that the fundus fluorescein angiography is relative contraindication. It's not an absolute contraindication. And also presence or absence of any kind of a macular edema changes in form of neurosensory detachment. And you will sometimes prefer steroid here as compared to anti-VEGF. So these are a couple of pointers we should be aware of.
So other thing, Piyushi, if I can add, is that you see the role of urea creatinine is going away. Nobody should be doing urea creatinine now, because what should be done is a microalbuminuria studies. You see, those are more rewarding, or 24-hour protein urea. That is very, very important. And the other thing which is assuming importance is eGFR. You see, eGFR is more relevant than any of the tests, because nowadays, even it is known that anti-VEGFs have a deleterious effect on the kidney status. So people say, instead of, apart from cardiology evaluation for any ischemic heart disease or other things, people say you should also have a eGFR done in patients before you undergo, because for last 2 years this has increased usually quite a bit. So apart from what Dr. Manoj said, remember, instead of urea creatinine, go in for protein urea, 24-hour protein or microalbuminuria if it's early stage, and eGFR. I think after that we can move on. And Piyushi, does it answer or you have some other question?
Yes, sir. Thank you, sir.
Okay. Please carry on.
Related to vein occlusions. Can we take them now?
Yeah, sure. Take it now only, because otherwise...
Yes. Differentiate hemi-CRVO and BRVO clinically.
Yeah. Manoj?
Yes, sir. I'll just show with an example itself.
Yeah. I think he showed a very nice picture actually, so which should clarify.
So here we have a HCRVO which involves more than 2 quadrants, or more than 1 quadrant, sorry. So it's going to involve one of the most commonly inferior, but it can be superior as well. So it involves like this, is basically the involvement of along the retina along the watershed zone, and this is a patient who has a branch retinal vein occlusions.
So Shefali, let me make it slightly more clear. Hemi-CRVO is basically a type of CRVO. Its prognosis and management, we don't manage it as a BRVO. BRVO, only one vessel will be involved. Hemi means half of the retina is involved. So typically we have a horizontal raphe going across the disc and macula. So either the inferior or the upper part is involved, and both the quadrants of that half are involved. And its management is obviously, prognosis is worse than that of BRVO, and the management is primarily based similar to how we manage CRVO. BRVO has a reasonably good prognosis. Natural history of BRVO is very, very good, and most of these patients sometimes are asymptomatic also, and we pick up, and vision generally is very, very good, and prognosis. So I keep telling my patients, if I have to have vascular block, BRVO I will have, not hemi-CRVO, not CRVO. So Then management, I think we can discuss later on, but this is what Hemi and BRV says.
I think why is there asymmetric macular edema in DRV?
Say it again, asymmetric macular edema in BRV or DRV?
It's because of only that part of the retina is involved.
I couldn't get the question, Manoj. What was he asking?
Asymmetric macular edema, sir.
In
BRVO.
You see, the thing is, if you see an OCT scan of BRVO, one of the leaflet will be normal. Okay, suppose the OCT scan is running, there is a central foveal avascular zone, so only one part will be affected. Rest of will be abnormal. Whereas in CRVO or a hemi-CRVO, generally the foveal contour is lost. Whereas in BRV, foveal contour can be there also. So you can make out very clearly on OCT alone whether it is the patient of CRVO or BRV or hemi-CRVO. I think let's move on because a lot of things have to be covered. We will come back.
So in the interest of time, so commonly asked questions related to macular hole, how are you going to define it? It's a full thickness depletion of neural retinal tissue in the center of the macula. Okay, it can be full thickness or lamellar, that is partial thickness, which is lamellar hole, seen in elderly population and can be unilateral most often or not. The second thing what they will ask you is what is the significance of epiretinal membrane. So basically it's nothing but a fibrocellular membrane which proliferates on the inner surface of the retina to produce various degree of macular dysfunction. Okay, so these are the two things we should be aware of. And what are the common causes of epiretinal membrane formation? Now coming to the recent classification of epiretinal membrane, this is of prime importance. You should be knowing this, something called as stage 1, stage 2, stage 3 and stage 4. In order of severity, this indicates the prognosis of that particular patient. So stage 1 is where you have good vision, very nascent looking membrane, not much of distortion on the fovea. But what examiner is here looking at is, you need to tell the examiner that inner retinal changes are not much in stage 1 and stage 2. So you are looking at the changes which are happening on the inner retinal surface. In stage 2 also the vision is relatively okay, but there is loss of foveal dip. So if you tell these 2 points, you are much more well versed than any other candidate. Whether in stage 3 and stage 4, you not only have distortion of the foveal contour, but you also have some kind of a degeneration which is happening on the inner retinal layers, and over a period of time this is called as ectopic inner foveal layers, which indicates poor prognosis. As what you can see here is called as EFIL, ectopic foveal inner layer. So this is a recent classification which you should be little well versed with. And commonly then they will ask you some kind of OCT related changes. So degenerative means, that means the tissue loss is there. So the name itself says degenerative, that means there is a tissue loss here. Tractional means there is no tissue, not much of tissue loss, but the changes in the tissue, that means the loss is not there, but this kind of a traction, that is the epiretinal membrane, is pulling along the foveal surface, causing the dysfunction of the retinal inner layers. So these 2 pointers you should be aware of. So commonly degenerative is something called as a top hat, and tractional is called as a mustache type of a pattern. So even if you know this much regarding the macular hole and epiretinal membrane, in a given case it is much more sufficient. And then what are the common causes? As I said, idiopathic is the most common cause, then trauma and high myopia. Other causes can be anyone, right, from anything right from DR to hypertensive retinopathy to choroidal neovascular membrane or cystoid macular edema. And what are you going to manage, how are you going to manage, or what is the recent classification related to International Vitreomacular Traction Study Group? So this much if we know is more than enough. Stage 1, 2, 3, 4 has not changed over a period of time, but the only thing what they are looking at is whether you are well versed with the terminology called as whole form factor, as how are you going to prognosticate or tell this patient what treatment will be required based on the OCT scan. So basically you are looking at the what is the maximum basal diameter, what is the minimal diameter, and what is the hole height, and based on this you can prognosticate that the patient can have a better visual acuity or not, or better chances of getting the hole closure post surgically. So this is what we are looking at, something called as a whole form factor, and what is how are you going to tell these patients, and what is a closure rate of this particular hole. the management part, nothing much to ask here. Is only thing is that we have to say that we need to peel the internal limiting membrane and put some kind of a gas. And then the second thing commonly asked is type 1 and type 2 closure. So basically type 1 closure is where the foveal contour gets maintained over a period of time, and type 2 closure is where you have a V formation. That means the foveal contour doesn't come back to normalcy. So in interest of time, I think we will just move on to a couple of more cases. This was the next case kept by us. What was vitreous hemorrhage? Basically vitreous hemorrhage can be due to various reasons, but most commonly one kept are related to vein occlusion or related to diabetic retinopathy. So how can you say what the patient has mild vitreous hemorrhage or dense vitreous hemorrhage, and what are the causes of vitreous hemorrhage over a period of time, and whether there was any preceding event for this particular problem, and associated systemic history, especially if the patient has a recurrent vitreous hemorrhage. So these 4 pointers you should be telling the examiner, and you should be examining it, and also whether the patient also has increase in intraocular pressure. RAPD, definitely the patient must be dilated, so we cannot just truly comment on it, but if it was documented earlier, then you can comment on this. And you will also like to do gonioscopy in each and every patient who have been presented with vitreous hemorrhage. This is very important. You tell the examiner again and again, you like to do a gonioscopy on a non-dilated pupil. This is very, very important. An examination of fellow eye can give you clue like diabetic retinopathy and so on. So that is very important. Again, differential diagnosis, it can be as simple as vitritis or asteroid halitosis or any kind of vitreous degeneration, or very rare causes like leukemia and so on. Investigation in this patient, these are again favorite questions. You divide into two, systemic and ocular, and then you go in a correct order both for systemic and ocular, and try to find the cause and defend your case accordingly. Now we have only couple of more minutes to be for this. Last thing I wanted to tell you something in vitreous hemorrhage. It can be very rarely a case of Eales disease. You should know looking for active vasculitis in these patients, and most often or not this patient might have bilateral problem. So examination of other eye is also equally important. In any kind of peripheral retinal phlebitis, that is vasculitis or vascular sheathing, should be looked very carefully just to trick the candidates, though this disease entity is very rare, but this kind of cases can be kept as a long case. You want to give any comment, sir, or we'll move on to the last lecture, Lalit, sir?
I think we should finish it off, then we can spend 10 minutes in discussion.
Yes, sir. So one other cases which are commonly kept is retinogenous retinal detachment. Most common or not, this is kept as a chronic cases, and it is basically separation of a neurosensory retina from retinal pigment epithelium. So definition should be by heart. You should be told in an exact manner. Retinogenous retinal detachment is a separation of neurosensory retina from the retinal pigment epithelium. What are the types of detachment? Only 3. It can be retinogenous, that is a break is there. It can be tractional, that is something pulling, or it can be exudative, that means the fluid is pushing it, or sometimes there is a combination of either of them. What are the factors which maintains the retinal attachment? I think Gopal sir has taken the lecture on this, so it should be well versed with all these things. And what are the normal vitreous adhesions? So this is the again commonly asked questions. What are the predisposing factors? So I have taken these points according to the questions which an examiner will ask you in that order itself, and which was expected from the candidate. So what are the predisposing factors? What are the prerequisites? Sometimes there are some kind of a prerequisites. The most commonest one is liquefaction of the vitreous and some kind of a pull on the retina. So these are two things we should be telling it. And what is the importance of finding the break in a particular patient? So basically you want to decide which type of surgery the patient will benefit from, whether it is a scleral buckle or a pars plana vitrectomy, and what is the importance in primary identifying the primary break or a secondary break. So the difference here is primary break is responsible for retinal detachment, and the secondary break are the associated breaks which has happened along the retinal detachment. Link off rule is one which we all should be familiarized with, and in any case of retinal detachment seen in your outpatient department, you should always follow link off rules. And basically here we are identifying the type of retinal detachment based on the location of the break. So that is the principle here. And what are the options or the principles of retinal detachment surgery is only three: to close the break, to relieve the traction, and to drain the subretinal fluid. If you just tell these three, you are got a distinction. So to close the break, to relieve the traction, and to drain the subretinal fluid. Then what are the different options? There are multiple options, but the most common ones what you have to mention is scleral buckling and vitrectomy if required, with some kind of a endotamponade. So even if you tell these two principles, that is more than enough. Very rarely we use something called as a pneumatic retinopexy as well. We will not go into the details of all these things. I think this thing you can read it out later on, or I can share my presentation so it can be easier for you to read it, memorize it. And the last thing, we should be always aware of any surgical thing. The favorite question of examiner will come on: what are the complications associated with that particular surgery? So definitely cataract is always there. Raised intraocular pressures, this fish eggs which happens mostly with PFCL bubbles or gas bubbles, and gas entrapment at the injection site. So these are all the common things which they will ask you. And definitely, what is the advantage of scleral buckle over vitrectomy? Still old examiners and the old time surgeons prefer scleral buckling. So we should be knowing what are the principles of scleral buckling and what are the contraindications. That means when the scleral buckling is cannot be done. And these are a couple of types of tires and sponges. If you are doing well, the examiner will ask you. Even if you don't know, doesn't matter much. But the principles of scleral buckling is something called as localizing the break. So this is the first important thing. If you just tell that I will try to localize the break, then I will try to compress the globe, that is the drainage. And I also try to do something called as a cryopexy. That means we will like to seal the break. So if you tell this thing, localization, drainage of subretinal fluid, and sealing of the break, that is more than enough. We'll just take one last one on dystrophies, then we will wind up. Most common case kept for any dystrophy case will be retinitis pigmentosa. Typically this patient will be in their 20s or 30s. So what is RP? That retinitis pigmentosa is a group of progressively hereditary retinal degeneration. There are various forms. The most common one is primary pigmentary degeneration, then tapered retinal degeneration, and rod cone dystrophy. So we should be looking at something like this. This case, when we kept in the exam, someone said pan-retinal photocoagulation. So you should not be confusing this kind of commonly kept cases. Young patient, typically looking with a lost face here and there, and everything, staring at your bony spicules with a chalky white disc pallor, arterial attenuation. This cannot be anything apart from retinitis pigmentosa. So three candidates told us that sir, this looks like a pan-retinal photocoagulation. So you should not be confusing yourself. The viva itself will move into some other direction. And whenever any kind of a dystrophic case is kept, the only interest the examiner has is right now is knowing the genetic pattern, whether you are going to assess the family members on the genetic side. So that is what they are looking at it, because gene therapy and stem cell therapy is going to come in a very big way, and this decade is actually indicated for a gene therapy now. And what are the features of typical retinitis pigmentosa versus non-typical retinitis pigmentosa? Okay, or it can be called as atypical retinitis pigmentosa. And some very rarely, if you are doing well, then it comes to the syntropic RP. Like commonest ones ask are Usher syndrome, Kearns-Sayre syndrome, Refsum syndromes. So we should be knowing couple of lines about all these things and take it forward from there. So lastly, they will ask you, have you heard of an entity called Leber's congenital amaurosis? So this is what we should be aware of, that it can be seen quite in early childhood, and there is a definitive treatment available right now only for Leber's congenital amaurosis. So a little bit about that treatment modality also. And there is no definitive management protocol available as of now, but basically we are looking at a family counseling, genetic counseling, and you need to follow up these patients with low vision aids. So this is what is commonly expected from the candidate. Couple of things which can be there on the treatment part is something like cystoid macular edema, cataract, and what is the role of gene therapy and retinal prosthesis in this patient, and how are you going to document this patient. So definitely the role of electroretinogram, both in form of full field ERG and as well as multifocal ERG. You should be knowing something about each and every entity. This is it from my side. I've cut down some cases due to interest of time, and all the best for your exams, and do well, and thank you so very much for the kind invitation once again.
So thank you, Manoj, for this presentation. Can we stop the slide sharing now?
Yes, sir.
So, Manoj, you must have said he was hurrying up primarily because the number of slides he had to show was too many. Because basic aim was, to give you a bird's eye view, and because not concentrate on one disease. So the aim of Dr. Manoj's presentation was, I could see that he was rushing through all the slides, and in fact, a lot of us could not read also what was written there, because aim was not to focally tell you about any disease. Aim was to make you aware, because he himself has been, examiner for long time. But ये long case आ सकता है और ये question पूछे जा सकते हैं. Obviously, he cannot answer all the questions of RD, all the questions of ERM, all the questions of whole or vascular block or diabetes. So, but these 7-8 conditions which he described, you should know, and common questions he has already hinted. But you see, my take on this thing would be long case. Never get nervous over it, because even if you do not know the diagnosis of that case, because what I found in my experience in RP center and other places was that people unnecessarily get confused. Suppose a patient will come which they've never seen. So it does not mean that you start crying or ask somebody to change your case or whatever. Because this has happened with me, because one of our residents, he said, sir, ye iske baare mein kuch nahi aata. Koi baat nahi. You see, issue is, believe me, no examiner is more intelligent, because you are the widest read that I'm telling you. सबसे ज़्यादा knowledge PG के पास होती है उस time पे. So don't get nervous over it. Concentrate on your findings. I told you last time also, concentrate on your findings. Like Manoj was very nicely telling, start with, retina के case में distant direct. Don't jump to this patient has retinal detachment with hole there. So you say media is clear, media is not clear. Then you say disc का क्या हाल है, vessels का क्या हाल है, macula कैसा है, periphery कैसी है. So go in that order, you will not miss. And even if you miss the diagnosis, does not matter. You will still score 90% of your marks. Because there will be very few finicky examiners who will, unnecessarily, trouble you. But by and large, most of the examiners want you to proceed in orderly fashion. In a long case, it is very important not to jump. Start from, like he said, best criteria visual acuity. Don't forget near vision. Don't forget color vision. Do not forget AMSCLER checking. My long case, I'm telling you, I had done this confrontation test, because I got retinitis pigmentosa in my long case. I'm talking of 81. So long case, I did that confrontation, and that examiner, you are so impressed at that time, इसने field charting भी कर लिया. So do not worry about about latest advances. Even if you do not know about Argus 2 processes, does not matter. Even if you know something is happening about bionic eye or artificial eye के बारे में कुछ हो रहा है, it's okay. So most important is to go stepwise. And I will advise that he also emphasized, Manoj, about systemic findings, about your systemic history, ocular findings, ocular history. Once you are examining, start from the lids, the conjunctiva, the puncta, whether they are relevant or not. You can say examination of eyelid, conjunctiva, punctum, cornea is unremarkable, so that he knows that you have already gone through it. If there are some findings there, then you describe. Otherwise, you say I did examine all this, they are unremarkable. So a lot of people say, did you check corneal sensation? So then if it is a corneal case, you should. Otherwise, you can come directly to the retina what he described. And very important things, do not depend that somebody will give you tools there. They will keep you basic tools. But you should always carry 78D, 90D or one of them, and 20D and indirect also. This is very, very relevant, because one of my colleagues, actually, he got a long case graduate, he did not do indirect, he was failed. So it's not possible that he don't do indirect examination. And AMSCLER, he has shown so many good drawings of AMSCLER. Because I am pretty sure that if you do good examination, you can actually tilt the questions what examiner should ask. Suppose you keep describing, sir, there is a detachment as per Linkoff rule, this thing. So he will start asking you about in Linkoff rules only. Then management में shift हो जाएगा सारा. You can actually tilt the questions which examiner want to ask. This I am pretty sure about it. And tools आप लेके जाओ, वो बड़ा important I think Manoj Khatri. And thrust is always on findings. Just any questions, Shefali, if are there, we would love to have it.
Basic question is how to clinically ascertain the plane of the lesion, like clinical pointers for like a pre-retinal sub-RP and choroid.
Manoj, you would like to take this?
What is the question? Can you come again, please? I was not able to.
Sir, how to clinically ascertain the plane of the lesion, like if the lesion is pre-retinal, subretinal, sub-RP or choroid, like clinical pointers.
Yes, so there are the three things what you should be clearly looking here is, one is the color of the problem. So if you take an example of a hemorrhage, whether it is pre-retinal, intraretinal, subretinal or sub-RP, so the color, so the lighter the color, the brighter the color, it is more likely superficial problem, that it can be pre-retinal, then comes the intraretinal, and then the extent of the hemorrhage. Now subretinal hemorrhages also can be extensive but unlikely, but more, like pre-retinal hemorrhages will be little more extensive with a sharply delineated borders. So when you look at the color, how the margins are, whether they are well delineated or not, and then look at the extent, and then you go about it. The last
other things, sorry, other things could be the majority of the pre-retinal hemorrhages will have feathery kind of edges. Also study relationship of vessel to the hemorrhage, because if the vessel is above it and vessel is clearly visible, you say it is, that vessel is coursing above it, that means you are hinting that it is either intraretinal or subretinal. And as you go deeper, as Manoj was saying, the color becomes darker. Sub-RP hemorrhage will be a dark color hemorrhage and will be better defined. Whereas pre-retinal hemorrhage, you see, like your flame-shaped hemorrhages in hypertensive retinopathy or ischemic kind of diabetic retinopathy, they have feathery edges and they will be along the nerve fibers. So the location of that you will tell you that this is a superficial kind of hemorrhage. And then OCT, in any case, you can delineate of pathology whether it is pre-retinal, subretinal based on the RPE level. Okay. So other questions, one or two more can be taken.
One person has asked about the definition of recalcitrant CME.
I think this we discussed already. This we discussed. First question we asked was this one.
Can white dot syndrome cases be kept as long cases, or but there are many? So, like any common ones that we should know?
Yeah, I think there are white dot syndrome. As far as I remember, there are 6-7 entities which are described there, which includes something like Doyne's honeycomb choroiditis, okay, which includes Mute syndrome, which includes AMPPE, even extensive colloid bodies. You see, these 5-6 things will come. AMPPE is also.
Can be kept. Healed surface sporadic. That's what we kept in one of the exams recently, about 3 years back, pre-COVID. So again, you should not be confusing that with something like a panretinal photocognition. The history will be a little different from the patient. So this kind of, mostly the cases kept will be inactive cases. So you should keep this thing in mind. APM, PP and all, they are little active cases, so may not be kept that commonly. And inactive or slightly chronic.
These cases, if at all, you see, these short cases we bring from the OPD. Long cases generally admitted kind of patients, so they will be different, variety. So, but since you have asked, so I told AMPP, multiple evanescent white dot syndrome, and multifocal choroiditis, and Doyne's honeycomb choroiditis. So all these can present. But if you want to know distinctive diagnosis of this, there is a chart available in the books. Like you see, patients of mutes have optic nerve issues. You see what we call acute idiopathic blind spot enlargement syndrome. The lesions are slightly larger, whereas in AMPP, lesions are slightly smaller and maybe tend to get bilateral. And history of influenza or flu-like symptoms may be there in AMPP. So it's a spectrum. In a white dot syndrome is spectrum. It's not a disease per se. It has various entities which are clubbed, because all of them present with whitish or yellowish or creamish dots on the posterior pole. So hence the terminology of white dot syndrome.
What about squint evaluation? How much in detail we should be doing it?
If Ali, what did you ask? What about?
What about the squint evaluation? The long cases, like there's a squint present in long case. Be done.
Squint evaluation in a long case.
No, that is a different chapter, because next series of chapters will be on squint only. But even if it's a long case in retina, you see, long case in retina does not mean that motility and all you should check. You see, but do not go into, suppose it's a patient of detachment. So I can't keep describing about, you see, underaction of LR and overaction of superior oblique or such things. But if grossly motility is okay, you should check all the 6 directions. You see, horizontal gazes, vertical gazes, oblique gazes. By and large, if suppose there is some abnormality, please note it down. Because this may have relevance in a diabetic patient also. With diabetic patients, sometimes you see if patient has diabetic retinopathy, there may be associated nerve pulses also. So motility is important. Okay. So therefore, I think you see thrust of whatever has been taught today is please proceed in a sequential way. Please do not jump to retina. If you jump to retina, you will make mistakes. So start basically from lid, conjunctiva, because lid may have ptosis, because that may again be a third nerve pulse. So start from the lid, from conjunctiva, from cornea, everything, lens. They may have diabetic cataract, they may have sunflower cataract, they may have snowflake cataract, they may have advanced cataract, which may change the management. Everything may be changed. So please go in a stepwise fashion, describe all the findings and take time. And wherever the findings are more, like detachment or visually more, so try to tailor your findings towards that, so the examiner is either led or misled into that type of question. Suppose you want to discuss about ARMD. So you say the DA7 examination of, adnexa, lid, conjunctiva, these things are within normal limits and there are no abnormal motility of this thing issue. And the thrust of the findings primarily are this, media is clear and there are issues of say CNVM or ARMD or this. And in ARMD I found out this. And do not forget other eye, because long case means both eyes have to examine. Short case में होता है कि spotter होता है तो you consider only on one this. Shefali?
We are not.
So I think Manoj, I think we did discuss 5-7 on issue. Bird's eye view of all the long cases has been described. I'm sure Shefali, Rolika, there will be huge number of questions in each of these things, and it's impossible for either Manoj or anybody else to keep describing all the things. But what we have told here is to how to work up a long case, how to systemically go. You see, as I said, even in the course of repetition, I'm saying do not jump to diagnosis. Go in a very orderly fashion, right from BCVA, near vision, color vision, each eye and pinhole vision sometimes if it is there. Then start from conjunctiva, lid, lacrimal system, everything you described. Long case में सब कुछ बताना. And then the thrust of finding. Suppose it's a retinal case, then you start from, you see media clarity, then slit lamp biomicroscopy with 70-80, 90D, and direct ophthalmoscopy and indirect ophthalmoscopy, and draw a diagram. Even though it is okay, suppose you have only drusen, or suppose you have only drusenate bodies, please draw a diagram. Please draw a diagram. As I said, if you are intelligent enough, you can skew your examiner towards asking those particular questions. No, Rolika?
Yes, sir.
Lead the examiner.
Yeah, definitely, 100%. कई बार ना सचिव बता रहा हूँ शिवाली, कई बार तुम्हें डायग्नोसिस नहीं पता होती ना. That's what I'm telling you. I have seen people topping that exam even though diagnoses are not very clear. But as long as you stick to evening RP center, Santosh would remember, we have that red file which we had to mug up. उसमें systemically सब कुछ वो 4 pages है, सारा कुछ लिखना. Then based on all the findings, then you say this is my DDX number 1, 2, 3, 4, and I would like to investigate from this point of view, and then this will be the, and then comes the management. You see, we are not expecting you everyday study or सारी बातें बताओ. After you have done all this, that will be later question after you have already distinction हो गया उसके बाद. ठीक है? So last punchline again is don't jump, concentrate on finding and findings. Okay.
Yes, sir.
Thank you so
I
much,
think
Manoj.
this is what Manoj wanted to say, and I could see him rushing through his slides because of time constraints also, and nobody can teach 10 long cases in 1 hour.
That's true.
Thank you, Manoj, for accumulating so many slides also. 252 was the number. I read that. 252 slides doing in 1 hour, and I think I think you rightly emphasized that बीच में सारे points rightly emphasized आपने कर दिया. This question can be asked and you should be ready. So I think on behalf of the entire CFS team, we again thank our guest speaker, guest star in fact, who took out time and इतनी स्लाइडें इकट्ठा करके he showed so many long cases, potential long cases.
Right, sir. Thank you, Manoj, sir.
Thank you, everyone. Thank you. All the best. Thank you so much.
Thank you. The next class will be on June 15th, and that would be the exam special OSCE in Retina by Dr. Sushma Rajay. So we'll all be there, and see you again.
Okay. Thank you. Thank you, everybody.
Thank you so much.